Alright, so this is going to be the first video for our final project / exam. Also, you're going to have to bear with me because I am currently sick and I probably will be coughing throughout this, so yeah. First thing we are going to talk about is steps of depolarization and muscle contraction within the heart muscle. And with this, I'm going to talk about how the signal is spread across the heart and how it actually exerts force. In addition, I'm going to talk about heart failure and how imaging modalities may be able to help us visualize the clinical pathology. So, when we think about depolarization, or at least from what we've learned about depolarization, is that there are a lot of ions involved that can cause the cell to become positive or negative. And with this, it's going to cause depolarization and repolarization to occur, as well as action potential. And we know that when action potential is reached, contraction occurs. So when we apply this to the heart, we know that the heart has two different kinds of cells. We have a pacemaker cell, and we have a contractile cell, also known as our myocyte. The pacemaker cell is autorhythmic, and so we're going to see this at the SA node, which is the primary pacemaker. Within this little graph that we have going on here, we have calcium in the blue, sodium is purple, and potassium is pink. So these are our three major ions that are used within this graph. So when we look at step 1, we're going to see that sodium kind of goes into the cell when it reaches negative 40 millivolts. And at this dashed line, that's going to cause calcium influx into the cell, which allows a further depolarization. We're going to reach a peak where calcium deactivates. And here we're going to see potassium ions leave the cell, and the voltage is going to return to negative 60 millivolts. And you're going to see the purple again start to spike up, and this is going to occur over and over and over again based on the heart rate of the heart. And that SA node is going to just be constant because it is our pacemaker, which is a modified myocyte. So now we're going to go over and look at the contractile cells of the heart, which are non-autorhythmic. Looking at this graph here, or this little chart, the same thing applies with the ions. We're going to be using calcium, sodium, and potassium. So there's a different bit of voltage going on here, but that just means that it's a bit more negative. So potassium initially is inside of the cell, which is at step 1. Once we hit step 2, we're going to see a bit of calcium and sodium enter in the cell due to the gap junctions leaking. So they're going to leak out of the gap junctions, and then sodium is going to quickly flood into the cell, creating a rise in voltage, so it depolarizes. Then at step 4, we're going to see around negative 40 millivolts, and the L-type calcium is going to enter into the cell. Here at step 5, there's going to be a bit of a dip. The sodium channels are going to close, and potassium slowly begins to leave the cell. At step 6, we're going to see the calcium gates are still open, and they enter into the cell. And then at 7, we're going to see a drop here where calcium gates are closing, and the potassium completely leaves the cell. Then step 1 is going to start all over again, and it's going to restart. So these are our two different depolarizations that we have going on within the heart, based off of where they are at within the heart. So pacemaker cell, it's going to be more primarily by the SA node, and then the rest of these myocyte or contractile cells are going to be throughout the rest of the heart, causing that up-down and then down-up contraction to occur. So now that we understand or have a general understanding of the two different depolarizations that occur within our heart muscle, we're going to look at the SA node, the AV node, and how this signal kind of goes throughout the heart. So looking at this first picture, we're going to look at atrial depolarization. This little yellow dot is going to show kind of where the SA node is sitting at. It's at the right atria, and it's going to send kind of like this signal across both of the left and right atria, where this is the like active contraction pushing the blood into our left and right ventricles. And so this is our pacemaker cells kind of listening to what the SA node and is saying with our heart rate. And so this will either be faster or slower depending on the heart rate. Then we're going to look at isovolumetric contraction. The AV node receives a signal, and it's going to send that signal down the left and right bundle branches, up and out through the Purkinje fibers of our left and right ventricles. And that signal then, when looking at rapid ejection, is going to tell the left and right ventricles to squeeze the blood up and out of the heart. And that's kind of what's going on with our heart cells. So now let's take a closer look into the muscle itself when it comes to the heart, or really just any muscle, but specifically we're going to look at the heart muscle here. We have down in the T tubules, trigger calcium is released. It's going to bind to the L-type receptors, where then it's traveled through the RYR feet and into the RYR receptors, where then inside of the sarcoplasmic reticulum, calcium ions are going to be released, and they're going to bind to troponin C, which allows calcium to either bind. No, it does bind. However, troponin I is actually going to be inhibitory, so it can block the binding of the myosin to troponin. And then we also have troponin T, which attaches to the tropomyosin. So when calcium binds to troponin C, it's going to allow that tropomyosin to shift, and troponin is going to allow the myosin head to grab onto the actin, and we're going to have muscle contraction occur. Calcium is then still going to be present within the muscle here, but it doesn't really have anywhere to go. So what's going to happen is circa is going to kind of act as a vacuum, and phospholambdin is kind of like the on and off switch. So phospholambdin is going to say, hey, we need to get this calcium back from where it was currently just being used, and circa kind of takes that calcium and starts to reuse it. And so we can also see here, looking at my beautiful drawing, we have other things going on. We have a lot of hormones can play into this. When looking at acetylcholine and ADO, these are going to be more inhibitory, so we're going to see a lot of PNS activation with this, which means this is going to kind of slow things down. So say we have our M1 and M2, it's going to signal the G inhibitory protein to cause kind of less activation of calcium to be used, whereas on the other side we have norepinephrine and epi that are going to be used and bind to beta 1 and beta 2 receptors, which actually stimulate our G protein, and it's going to cause more ATP to be used, allowing more calcium to be used, more muscle contraction, and this makes sense because of SNS activity. Now, when looking at force, we know that inotropy is super huge when it comes to the regulation of contraction. And if we increase inotropy, we're going to have an increase in contraction, which causes an increase in contractility. So, looking at preload here, we have, if we want to increase preload, which means that we want to have more filling into the left ventricle, then we want to have an increase in contractility and an increase in atrial inotropy. So that way we're able to get a lot more force to exert more blood out of the heart. And we want that for an increase in cardiac output. Now I'm going to discuss HFrEF and HFpEF, which are two different kinds of heart failure. So heart failure has two main causes. It's going to be coronary artery disease and myocardial infarctions, which are also known as heart attacks. When looking at HFrEF, this is known as systolic failure. HFrEF is heart failure with reduced ejection fraction. So this is when the left ventricle doesn't pump blood out of the body as well it should be. So it kind of impairs inotropy. That means we're going to have kind of this decreased shift in the Frank-Starling curve. And so we know that Frank-Starling is greater the stretch, greater the squeeze. So if we have a decrease in this means that the ability of the heart to compensate by the Frank-Starling mechanism becomes exhausted because the sarcomeres, they're not able to stretch to their maximal length. So this isn't ideal for the heart to kind of get blood out of the body as efficiently. We're also going to see a decrease in stroke volume because of this. So in order to combat this, a lot of medical professionals will kind of administer a combination of drugs, and so this is kind of used to reduce blood volume, preload and afterload to help with HFrEF. Then we have HFpEF. This is heart failure with preserved ejection fraction, also known as diastolic failure. So this is when the heart pumps normally, but it's kind of too stiff to fill properly. So there's not a lot of relaxation between the heartbeats, and kind of this stiffness is due to a decrease in lusitropy. And lusitropy just it means relaxation. So we're also going to see a decrease in ventricular compliance. And this is often due to uncontrolled hypertension. To kind of combat this, medical professionals can give beta blockers and calcium channel blockers to allow lusitropy to increase, so that way the heart isn't as stiff and blood can get out of the heart more properly. So in order to kind of look at heart problems, we're going to use cardiac MRI. And cardiac MRI just means magnetic resonance imaging, and we use this for magnetic impulses. And really it's going to look at soft tissue, so that is the heart. So the purpose of this is kind of to evaluate the size and the function of the heart. It can even look at blood flow, and really to detect any abnormalities or conditions like heart disease, heart attacks, like HFrEF, HFpEF, or even heart valve problems. And so just kind of to understand the background of MRI, we're going to have hydrogen molecules, and they're going to kind of reflect and shift here, looking at this little drawing I have going on. And so precision occurs, and that just means that it returns to spin. And that's what's going on here. The hydrogen molecules are just reflecting to allow imaging, or for us to see the imaging of the heart.